My pleasure to introduce Dr. Sanjay Sharma, our next speaker, professor at St. George's and a cardiologist with CRI. A reminder to the audience that Dr. Sharma and all the speakers welcome your questions, which we will address at the end of the session if you might post them online. Dr. Sharma.
Thank you very much, Megan, for the introduction. I'm going to be talking to you about veteran athletes' heart. Does sex matter? My conflicts are similar to those of Professor Papadakis. I have received grants from Cardiac Risk in the Young and from the British Heart Foundation in relation to this particular research piece. So males and females are separated by just one chromosome, but this single moiety is associated with numerous physiological, pathophysiological, neuroendocrine, psychological, biochemical changes. And so women are generally smaller, they have a lower body mass and muscle bulk, they have shorter bones and tendons, and in general have a lower peak oxygen consumption. So men are generally stronger, faster than women and have bigger cardiac dimensions. Conversely, women have lower blood pressure responses to exercise due to estrogen-mediated increase in nitric oxide. They have a lower prevalence of left ventricular hypertrophy. They're less likely to demonstrate systemic inflammation. They have less pronounced autonomic activity in terms of sympathetic outcomes. And their cardiovascular system ages a decade later than that of males. So they're less prone to cardiac maladaptation, and they're at lower risk of exercise-related sudden cardiac death. What we know about females thus far is predominantly derived from young women. So what do we learn from young athletes when we compare females versus male athletes? Well, here's a data set of 1,800 males versus 200 females. And what we note is that males are more likely to show voltage criteria for atrial enlargement and ventricular hypertrophy, as well as early repolarization changes compared to females. In terms of cardiac dimensions, this is a bar chart of 1,000 Italian Olympiads, where the females are in red bars and the males are in blue bars. And you will see that males have bigger dimensions than females. Around 48% of males have a left ventricular cavity size exceeding 54 millimeters, which is the upper limit of normal for the general population, versus only 8% females. And 14% of males have a cardiac dimension exceeding 60 millimeters versus only 1% of females. So it's clear that of all the influencing factors in cardiac adaptation, sex is important. But what about age? There has been an increased interest in veteran athletes for the last 2 decades, but data in female athletes is relatively sparse. We know that age is associated with reduced aortic compliance and reduced left ventricular compliance. It's also associated with reduced sensitivity of the heart to catecholamines and also sarcopenia, which all have an impact on cardiac adaptation. So what have we learned when we compare veteran males predominantly veteran males versus veteran young athletes? We found that veteran athletes are more likely to have a bradycardia and first-degree AV block compared to younger athletes, and more likely, to a small extent, have T-wave inversion affecting the anterior and inferior leads, as well as more likely to have early repolarization. When we compare small groups of male controls versus male athletes and female controls versus female athletes, and we do MRI scans on them, the general message is that compared with controls, veteran athletes have a 14% greater increase in left ventricular wall thickness and a 10% greater increase in left ventricular volume size. So if we compared that with the data that we have in young athletes, then 12% of veteran athletes have an absolute left ventricular wall thickness exceeding 12 millimeters, compared with only 2% younger athletes. So it seems that veteran athletes get more thickening of the left ventricle compared to young athletes. 20% of veteran athletes have a left ventricular cavity size more than 54 millimeters, compared with 48. So the message is that they're more likely to get hypertrophy, but less likely to get enlarged left ventricular cavity dimensions. All of the data that I've alluded to so far have involved very small numbers of female athletes. Only 30% of the cohort of veteran females, but this group of athletes is growing rapidly. They constitute about 40% of all marathon and ultramarathon runners. So it's my pleasure now to introduce what we have been doing for the past few years. So I'm going to give you data comparing 327 veteran male athletes versus 220 veteran female athletes. And you will see that they were roughly the same age, in their mid-50s. You will see that males were bigger than females, as is usually the case. The vast majority of our athletes were white. But they'd exercised for a long time. They'd been exercising for 33 years, training for up to 8 hours per week, and had engaged in so many competitions, 47 total competitions in males as a median, and 80 amongst females. The vast majority participated in running, cycling, swimming, or triathlon. Males had a bigger peak oxygen consumption due to their size, but they also exhibited a higher level of exercise-induced hypertension, and this may become important later on. So what did the ECG show? Well, in short, males were more likely to demonstrate voltage criterion for left ventricular hypertrophy than females, but females were more likely to demonstrate a slightly longer QT interval compared with males. Other than that, we did not find any significant difference, although there was a signal towards males having a higher prevalence of abnormal T-wave inversion according to the international ECG recommendations. Indeed, if we compare males versus females in terms of abnormalities on the international criteria, we find that 6% master female athletes have an abnormal ECG compared with 8.6% male master athletes, which does not achieve statistical significance. So there doesn't appear to be a massive difference in their ECGs. What about cardiac structure? As with the young, males were more likely to have an increased wall thickness compared to females by around 12%. And this translated to a 25% increase in left ventricular mass, or a 14% increase in the indexed left ventricular mass. We also found, in terms of absolute dimensions, male athletes had a bigger left ventricular cavity, but when this was actually corrected for the size, females actually had a slightly bigger heart, suggesting that women actually adapt by growing their ventricles, enlarging them in cavity ways, whereas males adapt by both growing their ventricles but also getting thickened hearts. In terms of the actual remodeling, we did not notice any difference between eccentric, concentric remodeling or concentric hypertrophy between males and females. So here's the distribution of left ventricular wall thickness measurements between males and females. The females are in the red bars and the males are in the blue bars. And you will see that this graph is shifted towards the right when it comes to males, and that males have bigger dimensions than compared to females. No female veteran athlete had a wall thickness more than 12 millimeters, as opposed to 6% of males who achieved a wall thickness of between 12 and 16 millimeters. And remember, these were mainly white athletes, so it appears that veteran males get a thicker wall than young white males. When we look at the left ventricular cavity size, the bar charts look very similar. Shift to the right for the males. 19% of male athletes had a left ventricular cavity size exceeding 55 millimeters compared to none of the females. So here comes the more interesting part. We know about physiological adaptation. We've been learning about that in sports cardiology for several years, in that athletes get sinus bradycardia, they get first degree AV block, they get a modest increase in cardiac dimensions, they have high peak oxygen consumption. But over the past 15 years or so, there is emerging evidence that endurance exercise may have deleterious effects in some athletes. We know from small studies that that AF is 5-fold greater in endurance athletes compared to sedentary healthy counterparts. There is data suggesting that up to 11% of male endurance athletes have very high coronary artery calcium scores exceeding 300 Agatston units, and between 11 and 20% of male athletes have myocardial scar. All data pertaining to exercise-induced arrhythmogenic right ventricular cardiomyopathy is derived predominantly from males. So what about females? Do females exhibit cardiac maladaptation. Well, here is our initial study that was published in Circulation, looking at athletes aged 54 years old who've been exercising for 31 years. Well, we had 106 male athletes versus just 46 females. And the first thing you'll see straight away, that the blue bars, that are the males had more coronary artery calcium than females, whereas 80% of females had a completely normal coronary artery calcium score. This was only the case in around 52% of male athletes. And if we look at very high coronary artery calcium scores, this is coronary artery calcium scores exceeding 300, they were predominantly affecting males, not females. When we looked at the morphology of these plaques and we compared male athletes with male controls, this box chart shows calcific plaques in yellow, mixed morphology plaque in blue, and soft plaque in green. Remembering that hard plaque, that's calcific plaque, is more stable than mixed morphology or soft plaques. Whereas males did have more coronary artery calcium, their plaques were predominantly calcified. Indeed, 70% of males had calcified plaques compared to around 30% of male controls. When we looked at females, whether you're an athlete or a control, any plaques that were present were predominantly calcified. So there was no difference between female athletes and female controls in the amount of plaque that they had. But here is some interesting data, really interesting as far as I'm concerned, looking at 220 veteran female athletes versus 67 healthy female athletes. These women were aged around 55 years old, and importantly, 67% were menopausal, so were no longer protected from the effects of estrogen. The female athletes had been exercising for 33 years. And this is the interesting part. As opposed to males, if you were a female veteran athlete, you were less likely to have a coronary artery calcium score of more than 0. You were less likely to have a coronary artery calcium score of more than 100. You were less likely to have a coronary artery calcium score exceeding the 70th percentile. So it seems that women are going the other way to men, that the more they exercised, the less we were seeing cardiac maladaptation. When we looked at the morphology of plaques, there was no difference between males and females. So in the small number of women that did have increased coronary artery calcium, what were the determinants? Well, we used a model where we put in any risk factor for coronary artery disease, years of exercise, age, coronary artery inflammation, parathormone concentrations, and the only thing that we could relate to coronary artery disease, by that I mean a coronary artery calcium score of more than 100 or a coronary artery calcium score exceeding the 75th percentile, was age. 21% of our female athletes were aged over 60, and coronary artery disease was almost confined to this particular group. What about myocardial scar? Well, let's start with minor focal fibrosis affecting the right ventricular insertion point, the papillary muscles, or the right ventricular trabeculae. We found that 44% of our athletes had minor focal fibrosis compared to 11% controls. And I should also point out we have not been able to identify an association between minor focal fibrosis and ventricular arrhythmias in our athletes, whether we look at Holter monitoring or exercise tests. Male athletes were more likely to have right ventricular insertion point fibrosis than female athletes. And if we looked at controls, the fibrosis was only located in the right ventricular insertion point, but not the papillary muscles or the trabeculae. So the one study that has had a lot of publicity is this study in middle-aged triathletes, of which 65% were male, and they trained very hard, and they were compared with 36 controls. In this study, 17% of triathletes had evidence of late gadolinium enhancement, all of which was non-ischemic and predominantly affected the infralateral area, with 5 having subepicardial involvement and 2 having insertion point fibrosis. And this is where the exercise-related blood pressure becomes important, because the determinants of scar in this particular study were a peak blood pressure. So males, clearly individuals with high blood pressure responses to exercise had more scar. Those with an increased left ventricular mass index also had more scar, as did those people that did a higher cycling mileage with more middle distance and Ironman events. In fact, this study showed that a completed cycling race distance of nearly 1,900 kilometers during a competitive race had a high sensitivity and specificity for scar. I should point out that all scars occurred in males and not females. Our own experience of nearly 200 athletes showed that when we look at major fibrosis, 11% of athletes have major fibrosis. This is almost exclusively in veteran male athletes, and it's independently associated with age, of which 1/3 of those with scar had ischemic pattern, 58% had a non-ischemic pattern, and 10% had two patterns. How did females fare? Indeed, in females, we predominantly saw scar in the right ventricular insertion points or the papillary muscle. Only 3 of our athletes actually showed scar elsewhere. Let me turn our attention to atrial fibrillation, which we know is probably one of the strongest findings that suggests that too much endurance exercise may have a deleterious effect in some endurance athletes. As you're all aware, that most studies examining atrial fibrillation in athletes have focused on males. So here's a meta-analysis which included 656,750 subjects, of which a large proportion, nearly 150,000, were female. And this is what the trajectory looks like. So we go from sedentary to intense exercise, where the males are the red line and the females are the blue line. With males, moderate physical activity protected from atrial fibrillation, whereas intensive exercise increased the risk of atrial fibrillation by 3-fold. Results with females were quite staggering. Moderate physical activity reduced risk by 8.4%, whereas intensive physical activity reduced it even more by 28%. In this large study looking at sex differences in atrial fibrillation and stroke in veteran endurance athletes, which included a lot of women, so the total number of people studied in these skiers was 208,654, of which nearly 40% were women. These people were compared with over 500,000 non-skiers. They were followed up for nearly 9 years, during which time there were 11,679 cases of atrial fibrillation and nearly 9,000 cases of stroke. Female skiers had a lower incidence of AF than female non-skiers by about 45%. In contrast, male skiers had a similar incidence to that of non-skiers, and male skiers with the highest number of races or the fastest finishing times had the highest incidence of atrial fibrillation. Among athletes that actually had atrial fibrillation, after the diagnosis of atrial fibrillation was made, long distance skiers had a 27% lower risk of stroke and a 43% lower risk of dying compared with individuals from the general population with a diagnosis of atrial fibrillation. And other studies have shown that even amongst females who do have atrial fibrillation, they do better than males. So my conclusion is sex does matter when it comes to cardiovascular adaptation to sport among veteran athletes. If you learned nothing, then just focus on this slide. When it comes to the ECG, males get higher QRS voltages and a higher prevalence of T-wave inversion, whereas females get a higher prevalence of QT interval. Males have an increased wall thickness, increased LV mass, and an increased absolute cavity size, whereas females have an increased indexed LV cavity. Males get a higher prevalence of increased coronary calcium calcification, increased myocardial fibrosis, and increased AF, whereas females seem to be protected from coronary artery calcification and certainly from AF. And this may explain why the risk of adverse cardiac events in marathons and ultramarathons is almost solely confined to male athletes. Thank you very much.
That's great. Thank you so much, Professor Sharma, for a really informative talk and a very useful update. And we look forward to the Q&As later.